Hi, everybody. I'm Lisa Swanson. I'm a dermatologist and pediatric dermatologist in Boise, Idaho. I work in private practice at Ada West Dermatology, and I'm affiliated with St. Luke's Children's Hospital. We have so many topical options now for our littlest patients with atopic dermatitis, and it can be hard to choose. So, what kind of things are we considering when we're choosing a topical agent to treat mild to moderate atopic dermatitis? A lot of that depends on the age of the patient. If the patient is 12 and up, you're really talking to the patient. What's important to you as a teenager, as an adult? What do you want out of the treatment? And it's really the patient in the 12 and the up category that's going to make that final decision. However, in the under 12 space, you're talking mostly to the parent. The parent is the one that's guiding this ship. And so you want to talk to them about what is most important in the care of the atopic dermatitis for your child. Regardless of whether you're working with the parent or the child, you get the sense that a couple things are most important. Number one, speed of improvement. Families of patients with atopic dermatitis want the eczema to get better quickly. The burden of the disease is so high. When one child has atopic dermatitis, the entire family suffers. And so the quicker they get better, the happier the family is. This also stems from the fact that a lot of our patients are used to using topical corticosteroids. And whether topical steroids are good or bad, they have their pros and their cons, they are fast. So that is what our patients are used to and what they want to achieve, but they love it to be a non-steroid. Then it has become quite clear to me that the second most important thing is, will it burn and sting? This especially applies to the under 12 space, especially the 2 to 7 or 8-year-old. These patients will not use something that stings. And if they use it and it stings, they're never going to use it again. They're going to cry if they see the tube come out. And so a lot of my patients want to know what's going to be the fastest and what's not going to burn and sting. And so that's when I bring up all the options. And I actually talk to patients about all the non-steroid options that we have these days. It's a wonderful time to be practicing dermatology and specifically pediatric dermatology. But I think topical ruxolitinib has so many strengths when it comes to these conversations with patients and their families, because we know that it works fast, especially for the itch. They have data showing itch improvement and itch reduction as early as 15 minutes after application. That is fast, you guys. And so we know that it kicks in. We also know that it is highly effective. We see that in the studies. We see that in real life. And we also know that it has wonderful tolerability, very little burning and stinging. So it's important to talk with your patients and their families about what they want from a treatment, and then discuss the treatments that we have available and see where everything kind of lines up. Once a patient and their family decide to start using topical ruxolitinib, let's say they choose that in this case, what do I tell them about as they prepare for their ruxolitinib journey? So number one, we know that topical Rux works fast. We know that it kicks in quickly for the itch. We also know that the endpoints in the trials were at 8 weeks. So it's important to talk about the speed of response, but maybe don't oversell it or overhype it, because in the trials, they gave it 8 weeks to see if it met those endpoints. What I tell families is that they're going to see a reduction in itch first. And isn't that the most important thing? And then it takes time for the skin to get clear. It's important to set realistic expectations. I've heard somebody say something recently that really stuck with me. If you warn somebody about something ahead of time, it's an explanation. If you tell them about it afterwards, it's an excuse. And so set them up for success. I expect to see itch improvement quickly. It might take a little bit longer for the skin to clear. 8 weeks was the endpoints in the trials. I also tell them that very little burning and stinging occurred, so I expect this to be tolerable. And if in doubt, I am lucky enough to have samples. I'll go grab a sample and I'll put it on the child and make sure that they tolerate it well. I recommend that they use the topical ruxolitinib twice a day as needed. Once clear, they can stop. And I often mention that in the long-term studies of topical rux, including our pediatric patients, they were able to stay off drug and not use topical rux about half the time. So they are going to be cycling on sometimes and they are going to be cycling off sometimes. But the fact that they only need to think about the atopic dermatitis about half the time, that is really meaningful. That's where we're giving them their time back. So they can you do something productive, like watch The Bachelor, which is what I do if I have some extra time on my hands. So give your patients the options, break down what they want from a treatment, talk about the medicine in a way that gives them all the information they know about what they can expect, and then set them on their way and plan for a follow-up in 8 weeks. And remember, take before and after pictures because it's pretty nice to look back in time and be like, wow, I can't believe it was ever like that. Isn't it so wonderful that we're here at the end now? So good luck. May the force be with you and go forth and prosper with topical ruxolitinib.